Hello, this is our second clip. Tonight I'm going to be talking a little bit more about gastroenterology and connective tissue disorders, EDS, and some of the more frustrating diagnoses that we might be trying to get. In my part one, I discussed some of the educational issues behind communicating with a GI about mast cell activation syndrome or mast cell activation dysfunctions, and ways that we can still have a positive experience and get benefit from those visits, even if they don't understand some of the nuances of mast cell instability. I did not address what I want to talk about more in this video, and that is lovely conditions like median arcuate ligament syndrome, different types of gastroparesis, slow colon motility, and it gets a little more twisted from there, but hopefully this won't leave you with colic. So, little GI joke, I know, feel free to groan. The foundational challenges that we end up having with most doctors starts in their education process. They had some chapters and pieces on Ehlers-Danlos, but even when they were writing the textbooks about EDS, they really didn't know how common all of these other rare conditions were or are in our bodies, or their variable presentations of them. And so the testing we need hasn't developed in a lot of ways. So a gastroenterologist is going to screen for mastocytosis. They're going to do patch testing called stains to look at the number of mast cells through different things like your esophageal lining and your colon and intestinal tract. And they're going to come back and say, unless you have mastocytosis, they're going to say, oh, you don't have a mast cell issue. What they mean is that your body is not creating too many of them. Those tests do not test for hyperactivation, where these mast cells react inappropriately at the wrong times, the wrong places. Like little toys on the table where you squish it down and the slightest shake makes them explode, and then other ones you have to flick to go off. Normal people take a harder hit. Ours, you look at them, they go, oh, we're gonna dance now. So what we really need is mast cell stability, and that is currently handled not by GIs, but by immunologists who have not as much gastro training, but because of immunology, tend to have more multi-system experience. The nature of immunology works that way. It's less focused on a particular organ and has to look at body systems and interactions. So we have a lot more good experiences with that kind of spectrum of doctor because their education was towards multi-system pieces. No one has everything on our picture. Research is still coming out, so when we're wanting to discuss and approach any of these and some of the more severe conditions, we run into this bump. Do they know what it is? How do they know what it is? Let's start with, gastroparesis is one of those things that you get an EDS diagnosis, and if you were anything like me, you're pretty scared that this might be one of your problems. It's related to our neurological function, and they tend to be progressive. They don't go into remission, they don't really become stable, and they're very difficult to treat, and as it advances, it just gets progressively worse and worse. The medicine and the ability to treat this right now is a real challenge. So getting a diagnosis, there's some of the simpler testing is to take pictures of radioactive food moving through your digestive tract and seeing if it's going fast or slow and what segments it's going fast or slow. That might be followed up by a smart pill, it's a little bit more nuanced, and they're using the computer to track the pill through your body. There's going to be other types of imaging, maybe ultrasound, and your colonoscopy and an endoscopy to look at different types of irritation injuries, other serious issues. One of the challenging pieces to those testing and images is if you have any problem with the sphincters, the valves that are going in between the esophagus, the stomach, duodenum, etc., all the way down through. And sometimes we can have issues with those valves. Testing for that is a lot more specialized. They have to put down a scope while you're still awake, usually, and test the pressure of the sphincter closing and see if it's closing tightly enough or if there's a gap in it. Sometimes they can bypass that by looking at the effects around it. So like if you have gastritis, that could be backflow from the acids creating irritation because they're not in where they're supposed to be. The tissues are not designed to handle that backflow. And so they might not do the pressure testing and the other expensive pieces because they see the evidence and that's the symptom. So you're set. The testing is not generally very nuanced. Someone could have motility issues that are advancing or progressing, and be experiencing quite real effects of them, but they don't show up on testing because it's not sensitive enough. And in that case, we do have to take more time to look for a GI that's dealt with those issues. And either through practice and experience or by a specific course of study, tried to work on those. And that is the same for the other big one I wanted to talk about, median arcuate ligament syndrome, which is a form of vascular compression, and there's related nutcracker syndrome, SMAS. These are all vascular compressions, where for one reason or another, a part of your anatomy is blocking blood flow through some rather major arteries and blood vessels to different parts of the body. I'm going to focus on MALS, since I've gone through the details of that experience, and you guys can Google the rest and research from there. But the process for MALS, they have to rule out all that other GI stuff I was just talking about. It's a long process. It's also considered to be extremely rare. And the challenge we have with this is that there are two different kinds of MALS, and some doctors don't even believe in one or the other. You have compressive MALS and neurogenic MALS, where the nerve of the celiac plexus behind the aorta in your stomach and the celiac artery, the nerves are damaged. A plexus is a grouping of nerve connections and ganglia all in one place. And that nerve cluster, that plexus, feeds a lot of electrical signals to your upper GI tract and your lower GI tract, interestingly enough. So if you have damage in that area, nerve irritation in that area, then it can cause a lot of other challenges and issues. And some of us are interested in finding out if, maybe there's actually a connection there to the motility picture, where it's causing issues in other ways. That's not that different from what we in the Ehlers-Danlos community experience with MALS. So my surgeon and some of the top people who treat this, I'm going to kind of go with the stereotype of good quality standards. Please bear in mind there's always exceptions. Is that you really have to treat this like neurogenic and compressive are both occurring. First of all, unless you open up the body or go in with a scope surgically, you can't see if there's inflammation in these nerves. All you have are the symptoms. Those symptoms might be motility related or pain and swelling. The plexus is way back by your spinal cord, so if my body is like this thin, it's going to be hard to see swelling up here by my sternum when the irritation is way back here. The irritation's going to be causing swelling and fluid back behind the stomach and through the abdominal cavities in other ways. So we burp, we have gas, we have things that don't look like this rare condition where the blood flow of the celiac artery coming down off the aorta, it should just kind of curve like this, and it gets bent by the median arcuate ligament, and it traps that and starts to cut off the blood flow and push the branch coming off the aorta. If this is the aorta and here's the branch, it kind of pushes it in and compresses it. Mine was almost ischemic, and that compression, especially it seems in Ehlers-Danlos, causes nerve irritation in the plexus that's right behind it. This is, again, one picture. There are idiopathic forms of this. There's forms of this that happen not in Ehlers-Danlos. This is within the connective tissue community where our cellular biology is more unstable. This tends to overlap the compression and the nerve irritation. Okay? And so they have to go and relieve the compression to allow the blood to move freely. And they have to go resect or snip away a section of the celiac ganglia. And in my case, they had to take out the entire celiac nerve. It was like optic neuritis is an autoimmune condition of the nerve in the eye. That's the closest thing I have to describe what this was like in my body. It was like my body was just attacking this one nerve. And so surgeon got in there and saw that and took the entire thing out. This was after I had been completely dismissed by most of an entire huge medical system, their chief of surgery, their chief motility specialist, their vascular surgeon, even with imaging showing the severe compression and all of my symptoms. They decided I was making it all up. Joy to the world. So I've been there. And finding a team to diagnose this is tricky, but they tend to not be gastroenterologists. Some do specialize in this if they really know what to pay attention to within the body. But because their training is focused on so many other areas, and because this condition affects our nervous system and our vasculature, it really takes some special nuanced perspectives in order to diagnose it. Now, in the case that I had where the system decided I was making it up, the motility specialist pulled in a neurologist who pulled in the chief of surgery and pulled in a vascular specialist. The problem is that a neurologist had decided that I didn't have Ehlers-Danlos, and so everyone else went off of his notes, never saying anything to me to my face in our appointments, but writing things in my notes. And that kind of bias is sadly part of the picture that we face. The ignorance, the lack of education. There's nothing we can do in those scenarios to communicate better or differently. Y'all, it's frustrating, and it's not the system. It's the impact of individual people and their lack of education. And a personality that just lacks creativity and curiosity, honestly. They get into boxes, and I say this as a teacher. I blame things much more on the education of what happened than on the system they were working in. The hospital system itself could have supported the diagnosis, could have treated me, probably not very well. I'm glad I ended up where I did, but they certainly got me to enough professionals. They got me to all the different specialists, but the personalities of those doctors and the nature of their education had biased them against multiple pieces of my case, and you can't do anything with that. You have to go somewhere else. There's no way to say it better, and I really mean that for those of you watching this. Who've been through that. It's not your fault. Maybe here and there's things we could learn, but at the end of the day, it's not something you could have done differently. It's how they were trained. All right? So, to wrap this up, In the picture of mals, they have to do a specialized ultrasound with certain breathing patterns to watch your diaphragm move. They have to do nerve blocks and see if numbing helps with the pain and the nausea, and you feel full really early. Some people are vomiting. I didn't have as much vomiting, but by the time I got my surgery, I was struggling to get 500 calories a day, and no one was going to give me TPN. Eventually, we kind of got fluids, but my veins can't do that all the time. It can get pretty dire for a lot of the women going through this, and occasionally there's a few men in that picture in the EDS community. So your average GI has no idea how to order that ultrasound. My cardiologist was the one who caught it after feeling my body and feeling the area. And I was lucky to find a GI eventually who didn't think I was making it up, but he still couldn't treat it. That wasn't his specialty or his training. Vascular surgeons are your go-to for that. So here's a condition where all the symptoms seem GI related, but the actual issue is vascular and neurological. Good luck getting a neurologist to diagnose mals, right? So that's a place where we can develop the awareness of this and build the team to fit. We have some great people in North Carolina and a community around mals with an awesome surgeon and team that can diagnose and treat, and where simple things, communication, addressing symptoms, and walking through the steps can actually be effective. The gastroparesis, a lot harder. I'm sure some of you watching this are living with that and struggling with that too. So when we have those scenarios, know that you can always call the doctor's office ahead of time and ask questions. Sometimes you can even get a chat with the doctor over the phone before going in. That's a little bit more rare. Takes a little more patience and weeks to call back. Occasionally an advocate like myself, I can call in with a little bit more of an official capacity and questions and get on the phone with a physician, with an immunologist, with a GI, and ask some specific questions about the client that I'm helping, saving the time and energy. The second thing you can do is always treat that first appointment like an interview. And I'm going to do a part 3 about approaching specialty appointments in a short clip. Stay tuned.